The persistent rise in chronic obstructive pulmonary disease, COPD, among women has become a growing concern in public health. Once considered primarily a smoker's disease, and particularly one afflicting older men, the trend has clearly shifted. Current data now show that women are not only catching up to men in terms of COPD incidence, they're surpassing them. And while the prevailing theory has long been that women are simply more sensitive to the harmful effects of smoking, the latest research casts significant doubt on this explanation. More concerning still is that a considerable proportion of women with COPD have never smoked at all, suggesting deeper and potentially more insidious factors are at play. The most alarming aspect of a study published in BMJ Open Respiratory Research is the revelation that nearly 1 in 4 women diagnosed with COPD has never smoked. In fact, the prevalence of COPD among female non-smokers, 3.2%, is nearly double that of male non-smokers, 1.7%. This finding effectively debunks the oversimplified idea that smoking exposure alone, let alone a heightened female sensitivity to it, is enough to explain the gender disparity. The idea that COPD in women is largely self-inflicted due to lifestyle choices like smoking now appears both outdated and dangerously misleading. What's even more troubling is that despite women smoking less intensely than men, fewer cigarettes per day, and less early life exposure, they are still being diagnosed at higher rates. This suggests that even equal exposure to tobacco smoke doesn't translate into equal risk. But interestingly, the study found that for every 10 pack years of smoking, the relative increase in COPD risk was virtually identical between genders, 18% for women versus 19% for men. That strongly indicates that women are not inherently more biologically vulnerable to smoking-related lung damage, as was previously assumed. Instead, it points to alternative mechanisms or environmental contributors that disproportionately affect women and have not been adequately studied. One likely suspect is air pollution and occupational exposure to lung irritants, which were not accounted for in the study due to the limitations of the self-reported survey format. Many women, particularly those in lower socioeconomic brackets, may be exposed to indoor pollutants from cooking fuels, cleaning chemicals, or poorly ventilated environments, all of which are known to cause chronic respiratory irritation over time. Yet, these risks are routinely underappreciated in both research and clinical diagnosis. Moreover, gender bias in medical assessment could lead to underdiagnosis or misdiagnosis in men, or conversely, to more aggressive screening in women due to greater healthcare utilization, thus skewing the statistics. Physiological differences may also play a significant role. Women's narrower airways, even when adjusted for body size, could make their lungs more susceptible to long-term damage from any kind of airborne irritant. These smaller passageways are more prone to collapse under stress, which could exacerbate the airflow obstruction typical of COPD. Furthermore, there is emerging evidence that inflammatory responses to lung damage may differ between men and women, potentially altering disease progression and severity. If true, this could have profound implications for how we treat and monitor the disease in female patients. All of this points to a harsh truth. We may have fundamentally misunderstood how COPD develops in women. By focusing too narrowly on smoking and assuming it acts the same across genders, medicine has failed to grasp the broader environmental, biological, and possibly hormonal factors that might be driving higher COPD rates in women. This blind spot is dangerous, not only because it leaves many women at risk without proper prevention strategies, but also because it perpetuates diagnostic inertia. Doctors may be less likely to consider COPD in a female patient who has never smoked, delaying the diagnosis until the disease has significantly progressed. The limitations of the study, such as self-reported smoking habits and a lack of data on occupational exposures or family history, must be acknowledged. But even with these constraints, the findings serve as a powerful wake-up call. COPD is not just a smoker's disease, and it is certainly not just a man's disease. Until we move beyond outdated assumptions, we risk missing crucial opportunities to understand and combat this debilitating illness more effectively in women. The implications for public health policy and clinical practice are clear. We need better gender-specific research into COPD, including longitudinal studies that track exposure to a broader array of environmental and occupational pollutants. Screening guidelines should be reevaluated to ensure that women, especially non-smokers, are not falling through the cracks. And public awareness campaigns must expand beyond anti-smoking messages to educate about the lesser-known risks contributing to lung disease in women. Failing to address these discrepancies is not just a scientific oversight. It is a failure of equity in healthcare. As the number of women suffering from COPD continues to grow, the medical community must confront the uncomfortable truth. The disease's gender gap cannot be explained away by tobacco alone. We need a more nuanced, inclusive, and evidence-driven approach to understand why women are increasingly bearing the burden of a disease once thought to affect them less. The cost of continuing to ignore this complexity will be paid in worsening health outcomes and avoidable suffering.